Professor Amr, unmute please.
السلايدز باينه؟
باينه.
اوكي شكرا. بسم الله الرحمن الرحيم. Management of elder patients with diabetes. Before I start, I would thank Professor Nashatut for inviting me to participate in this meeting. Also to Novartis. My agenda is demographics of aging and epidemiology of diabetes in older adults, health hazards in older adults with diabetes, altered glucose metabolism with aging, pathogenesis and clinical presentations of diabetes in old adults. Does diabetes care differ in old people than the younger or not? And at the end, I will give some remarks concerning therapeutic interventions in older adults with diabetes. First, I will speak about demographics of aging and the epidemiology of diabetes in older adults. What's the definition of elderly? Conventionally, elderly is defined as a chronological age of 65-year-old or older, and there is a classification for the elder population: young, old from 65 to 74, old from 75 to 84, and old above or equals 85 years. This slide shows the increase in life expectancy from 1950 to 2012, and was expected in 2050. As we see in 1950, this the average life expectancy all over the world in blue is 47 years. This increased to 71 years in 2012. I expect to increase more in 2050. This red color in developed countries, and the yellow in African lowest expectancy or the lowest life expectancy in Africa, as you see. Increased life expectancy is a significant contributing factor for diabetes epidemic. In 2000, number of people with diabetes all over the world was 56 million and expected to be doubled in 2030. In US, prevalence of diabetes in older people was 25% in 2010 and expected to reach 26.7 million in 2030. Is now in absolute numbers is 11 million. It was 11 million in 2010 in US and expected to reach 26.7 million in 2030. Now what about Egypt? Population aged 65 years or more increased from 4.3% in 1972 to 5.3% in 2022. It's now about 5.6 million living in Egypt. Their age is above 65. In 2015, the diabetes prevalence in patients or in people above 65 is 23% in Egypt. This versus the general prevalence, which is about 50% in population from 19 to 79 years, according to the IDF 2015. What are the health hazards in elder adults with diabetes? Elder adults with diabetes are at higher risk than those of the same age without diabetes. First, they have earlier mortality, especially coronary artery disease. Coronary artery disease is the leading cause of death in this population. Comorbidities as hypertension and cardiovascular disease and stroke are more common. Polypharmacy, also the common geriatric problems as cognitive impairment, sarcopenia, functional disability, frailty, depression, urinary incontinence, falls, and persistent pain. Cognitive impairment, I will speak about cognitive impairment. Older adults with diabetes are at higher risk of cognitive function decline, which ranges from slight cognitive impairment to memory loss to overt dementia than those without diabetes of the same age. What are the risk factors of cognitive impairment in patients with diabetes, in older patients with diabetes? Number one, poor glycemic control, longer duration of diabetes, and recurrent hypoglycemia. However, control of diabetes was not associated with improvement in cognitive function. Impact of cognitive impairment on diabetic patients, older diabetic patients. Impaired ability, number one, impaired ability of self-care procedures as glucose monitoring or adjusting insulin doses, and this will result in failure of achieving the patient glycemic goals and increased risk of hypoglycemia. Screening, there is a screening tool for the cognitive function, which is the mini mental state examination test. This test include many functions as orientation, registration, attention, recall, and language. Everyone takes a score and is collected at the end. 23/30 no cognitive impairment, 19 to 23 mild impairment, 10 to 18 moderate impairment, or 0 to 9 this severe impairment in cognitive function. In addition to impaired cognitive function, impaired functional ability. In older patients with diabetes, there is impaired protein senses and increased protein breakdown in the muscles. This is due to insulin resistance in the muscles, hyperglycemia, obesity, increased visceral fat and muscle fat, age, advanced glycation in the products, oxidative stress, and inflammatory mediators. All these factors participate in decreasing insulin, decreasing protein senses, and increasing protein breaking down. Diabetes in older adults is associated with acceleration of the age-related loss of muscle mass and strength, especially in the lower limbs. Sarcopenia is loss of muscle mass and strength, both together, which normally starts after 30 years. This will result in functional limitations and disability, more weight gain, and poor glycemic control. Poor glycemic control and longer duration of diabetes are risk factors for sarcopenia. Peripheral neuropathy, arthritis, stroke, also in older population, aggravates the functional disability. Frailty. Frailty is increased vulnerability for adverse health outcomes due to decline in the physiological function and reserve in different body systems. Frailty is better predictor for mortality than chronological age. Frailty is present if 3 or more of the following criteria are present: unintended weight loss, more than 10 pounds in the past year, self-reported exhaustion, weakness that is tested by grip strength, slow walking speed, and low physical activity. Also, there is a simple test for functional state status assessment. Many tools are asked, and everyone takes score: I independent, A or assistance is required, or D dependent. These functions as using telephone, traveling, shopping, preparing meals, housework, taking medicine, managing money. All these questions are asked to the patient or his relatives, and if the patient is either independent or requires assistance or dependence. Altered glucose metabolism with aging, pathogenesis, and clinical presentation of diabetes in older adults. This slide shows the pathophysiology of diabetes in elder adults. In elder adults, increased how aging is associated with increased insulin resistance and beta cell dysfunction. Many factors contribute to the insulin resistance in elder population, as obesity, especially visceral fat, and increased muscle fat, sarcopenia, reduced physical activity, mitochondrial dysfunction, and oxidative stress and inflammation. Many factors also contribute to beta cell dysfunction, as mitochondrial dysfunction, reduced glucose transporter 2 levels, ages, telomere shortening, impaired calcium ion handling, and reduced response to GLP-1. All these factors contribute to beta cell dysfunction, and both together insulin resistance and beta cell dysfunction result in age-related impairment of glucose homeostasis and diabetes. Majority of patients with elder adults with diabetes are type 2, and those are classified either older age onset, diagnosed after 65 years, and these constitute about 1/3 of patients, or middle age onset, diagnosed in middle age before 65, and those contribute to 2/3 of patients. Also, with better diabetes care, many or a significant number of type 1 patients are living beyond 65, but they constitute a small percent and are known from the start they are type 1. Microvascular complications, especially retinopathy, are more common in the middle age onset than older age onset patients, but both types are associated with increased risk of cardiovascular disease. Does diabetes care differ in elder people than the younger or not? Presenting symptoms, the symptoms of hyperglycemia may be absent due to age-associated increase in renal threshold and decreased thirst sensation. Diabetes is discovered accidentally during medical checkup or preoperative evaluation. Complications as severe dehydration, hyperosmolar hyperglycemic state are common in old age. Chronic complications of diabetes as vitreous hemorrhage, foot ulcers, and CKD are common. Incontinence, fatigue, functional cognitive dysfunction may be wrongly attributed to aging. This is a problem in older patients. Sometimes these geriatric manifestations are wrongly diagnosed as geriatric manifestations, but actually the patient has diabetes. The criteria for diagnosis of diabetes in elder population is the same as younger people. What's about diabetes care in older adults? Number one, glycemic control. According to the individualized goals, individualized therapeutic interventions, and avoiding hypoglycemia. Global cardiovascular protection, screening for microvascular and macrovascular complications, screening for geriatric problems, screening for depression, and this is very important problem in old age, preservation of quality of life. Management of elder adults with diabetes is challenging because of the wide variation in cognitive function and functional status, multiple comorbidities, and life expectancy in older people with diabetes. Older people with diabetes are heterogeneous group. Not all the older population with diabetes are the same. There is a wide variation in cognitive function, functional status, and this is reflected on the management. Only as a problem is only few clinical trials examine the benefits of intensive glycemic control and the management of cardiovascular risk factors, specifically in elder individuals with diabetes. The therapeutic goals and interventions were derived from clinical trials that included, but not limited to, older adults with diabetes. The UKPDS excluded older population. The other three studies, Accord, Advanced, and Vetted, they didn't find a benefit from intensive glycemic control in elder people on macrovascular complications. In this study, A1C above 11 was associated with increased mortality, and also A1C below 6 was associated with increased mortality, but weaker than the the A1C, the higher A1C law above 11. Therefore, there is no convincing evidence that old people with diabetes will benefit from intensive glycemic control. Older adults are at high risk of hypoglycemia than younger patients for many reasons. Number one, age-related progressive decline in renal function, poor or irregular food intake, hypoglycemia and awareness, blunted physiological response to hypoglycemia, and identified cognitive impairment. Hypoglycemia should be avoided in elder adults and should be managed by adjusting glycemic targets and pharmacological intervention. Whether cardiovascular risk reduction in elder adults with diabetes is beneficial or not, treatment of isolated systolic hypertension or combined systolic diastolic hypertension in elder people with diabetes is associated with a significant reduction in cardiovascular morbidity and mortality and microvascular events. So hypertension should be treated in virtually all older adults with diabetes. Statin showed reduction in major adverse cardiovascular events in elder adults with diabetes in primary and secondary prevention trials, no benefits with fibrates. Aspirin is effective in reducing cardiovascular events in older adults with diabetes in secondary prevention trials. However, its role in primary prevention trials is less certain. Also, aspirin increases the bleeding risk in elder adults than younger adults. For patients 65 years or more, a consensus assessment from the ADA and the American Geriatric Society recommends adjusting treatment goals for glycemia, blood pressure, dyslipidemia, according to many factors. Number one, presence of comorbidities, functional status, cognitive impairment, and life expectancy. They are classified to three groups. Group one, healthy, patients with few comorbidities and intact cognitive and functional status. These patients have longer remaining life expectancy to gain benefits of long-term intensive diabetic management, and so they should receive diabetes care with goals similar to those developed for younger adults. They are managed as younger patients. A1C target is relaxed to some extent, less than 7.5, fasting from 90 to 130, bedtime from 90 to 150, blood pressure goal less than 140/90, statin if tolerated and not contraindicated. Statins are used for secondary and primary prevention if tolerated and not contraindicated. Aspirin for secondary prevention and for primary prevention only in patients with 10-year atherosclerotic cardiovascular risk more than 10% who have low risk of bleeding. The other group is a complex or intermediate group. Patients with multiple comorbidities, multiple means more than three or more comorbidities, but mild or moderate comorbidities, not end organ failure, or two or more impairments in instrumental activities of daily living, or mild to moderate cognitive impairment. And so assessment of these patients to the daily instrumental activities very essential, and or the function state of the patient is very important. Also, the cognitive function should be assessed in patients, elder patients with diabetes. These patients have intermediate remaining life expectancy. The therapeutic goals are relaxed because of the high treatment burden, vulnerability to hypoglycemia, and increased fall risk in these categories. These patients include heart failure class 1 or 2, CKD not requiring dialysis, arthritis, or patients with COPD but not respiratory failure. As I mentioned, no end organ failure. A1C is relaxed to less than 8%, fasting from 90 to 150, bedtime from 100 to 180, hypertension less than 140/90, statin if tolerated and not contraindicated. Several drugs needed to be titrated or discontinued according to the liver function, renal function status. The third group, very complex or poor health. These are patients with end-stage chronic illnesses or moderate to severe cognitive impairment, or with 2 or more instrumental daily life dependencies. These patients have limited remaining life expectancy and are vulnerable to hypoglycemia, so they will not benefit from the long-term effects of intensive glycemic control. As we remember, the UKPDS study, the intervention part was 10 years and the follow-up was 10 years. And so these patients with end-stage diseases, end-stage heart failure, end-stage renal failure, end-stage respiratory failure, they will life expectancy is short, and so they will not is not expected to live to get benefit from intensive glycemic control. On the other hand, the risk of glycemia, which is a fatal complication in these patients, is more likely. Therefore, these patients should be treated to glycemic goals that prevent symptomatic hyperglycemia to avoid dehydration and poor wound healing. These patients should be treated just to prevent symptomatic hyperglycemia, dehydration, and poor wound healing, as I mentioned. A1C is less than 8.5, fasting from 100 to 180, bedtime from 110 to 20, blood pressure less than 150/90. Also consider the likelihood of benefit with statin for secondary prevention more than for primary prevention. I will give some remarks concerning the therapeutic interventions in adults with diabetes. Lifestyle changes, drastic dietary restriction is avoided in frail and very ill patients with moderate restriction in calories in obese patients. Physical training should be supervised and individualized after careful evaluation for underlying cardiovascular disease or musculoskeletal problem, and include aerobic exercise. This improves aerobic exercise, improve markers of cardiovascular morbidity and mortality. Strength improves muscle strength and decreases visceral fat, resulting in improving insulin resistance and glycemic control. Balance improves balance and reduces falls. Pharmacological therapy, special care is required in prescribing and monitoring the pharmacological therapy in elder adults. Metformin is the first line antidiabetic agent to be used. Monitoring renal function better by estimated GFR. Dose is reduced GFR from 30 to 45 and is continued low if GFR less than 30. Sulfonylurea are associated with weight gain in this population. Hypoglycemia is common in patients receiving long-acting sulfonylurea as glibenclamide, and are preferred in patients with are associated with hypoglycemia, especially with long-acting sulfonylurea. So glyburide, this is lower glibenclamide, is avoided. Rivaglinide and actiglinide are associated with lower risk of hypoglycemia than sulfonylurea and are preferred in patients with regular eating habits. Acarbose but is not available now in Egypt, is associated also with low risk of hypoglycemia, but associated with GIT side effects as bloating. Thiazolidinediones associated with low risk of hypoglycemia, but also there is increased risk of fluid retention. So avoid in patients with heart failure or at risk of heart failure and uncontrolled hypertension. Also increased risk is associated with increased risk in elder women, contraindicated in congestive heart failure and osteoporosis. D4 inhibitors is a very good option in old age, associated with low risk of hypoglycemia. They are weight neutral. Regarding cardiovascular safety, all of them are safe except saxagliptin was associated with increased hospitalization for heart failure. Also, GLP-1 receptor agonist. GLP-1 receptor agonist is associated with low risk of hypoglycemia, also associated with weight loss, so they are very suitable for obese patients. However, they are associated with nausea and vomiting, also diarrhea in some patients, and this may increase the risk of dehydration in these patients. And also they are more injectable. There is now semaglutide, oral semaglutide, but is not available now in Egypt. And so these drugs being injectable need intact vision, cognitive, good cognitive function, and motor skills. Also avoid in patients with gastroparesis. Sodium glucose transporter 2 inhibitors also associated with low hypoglycemic risk. Also, they are associated with, as empagliflozin, for example, are associated with decreased cardiovascular events in patients with cardiovascular disease. Also, decreased hospitalization for heart failure, but avoided in patients with GFR less than 30. Older patients may be at high risk of dehydration when these drugs are given, especially also especially if they are receiving diuretics, and there is a decreased thirst sensation, as we know in older patients have decreased thirst sensation, and this may expose them to dehydration. So at least initially, these patients should be warned, or the caregiver should be warned about good fluid intake and monitoring the patient for dehydration. Insulin aging should not be a barrier for insulin treatment when indicated. When it is indicated if there is symptomatic hyperglycemia, failure to reach glycemic goals with other drugs, severe acute illness, hospitalization, surgery, advanced renal or liver disease, older patients with type 1. The increased risk of hypoglycemia, the main side effects here, increased risk of hypoglycemia and weight gain. Insulin regimen, either basal, intermediate acting insulin as NPH, or long or ultra long, which are preferred in the older population, which are associated with lower risk of hypoglycemia, as Melargine 300 or Tracibel, I don't remember. Okay. Premixed insulin offer better convenience and good glycemic control. Is a simple regimen, but it needs a fixed lifestyle. More associated with increased risk of hypoglycemia and weight gain than in the basal bolus. Basal bolus regime in older adults with a chaotic lifestyle with intact cognitive and physical abilities. To improve insulin treatment in elder patients, use of premixed or pre-filled pens reduce those errors. Use simplified regimen as much as possible to decrease risk of hypoglycemia. Vision, cognitive function, motor skill should be evaluated before prescribing insulin. Education of the patient and caregiver about self-monitoring of blood glucose, hypoglycemia symptoms, and management. Use of insulin analogs instead of insulin decrease risk of height. Take-home message: the number of elder adults with diabetes has risen in the past few decades and will continue to rise in the coming years. Older persons with diabetes are at increased risk of early mortality, many comorbidities, cognitive impairment, functional disability, and frailty. Avoiding hypoglycemia is an essential target in the management of all elder adults with diabetes. Assessment of medical, functional, mental, social, geriatric domains for management of elder adults with diabetes provides a framework to determine targets and therapeutic approaches. Relatively healthy elder adults with significant life expectancy should receive diabetes care with goals similar to younger adults. In patients with significant comorbidities, cognitive impairment, functional disability, and limited life expectancy, glycemic goals are relaxed to goals that prevent symptomatic hyperglycemia. Management of cardiovascular risk factor is an integral part in diabetes care in elder adults. Thank you.
Thank you very much, Professor Amr.
Thank you, Dr. Ines.
Waiting for the questions.
مفيش ما عنديش اسئله.
لسه بيتقالوا. اتفضل.
في حد بيقول لي ساكساجليبتين كونترا انديكيتد ان هارت فيلير. ايوه هو يس ساكساجليبتين in cardiovascular trials was associated with increased hospitalization with heart failure, and so it's contraindicated in patients with heart failure or patients with at risk of heart failure. Intermittent fasting with diabetes. Not about this point. Intermittent fasting with diabetes. I think it depends on the type of the diabetes. It is not possible in type 1 at all. In type 2, it depends on the treatment. If the patient just receiving metformin, receiving the DPOR inhibitor, drugs not associated with hypoglycemia can be used in patients with diabetes. But if a patient receiving insulin, receiving sulfonylurea, will expose the patient to hypoglycemia. Also, a very important point, at the time the patient takes meals, should takes moderate calories, not simple sugars, not very high caloric diets, because this results in fluctuation of blood glucose, and the fluctuation of blood glucose itself increases cardiovascular morbidities or complications. I think Dr. Ines have an opinion about this part.
Intermittent fasting
in patients with diabetes.
Intermittent fasting, like you said, Professor Amr, can be done in certain types if the patient is taking non-hypoglycemic medication, anti-diabetic medication, not for sure, not insulin or sulfonylurea. It's, I think, contraindicated to do intermittent fasting with sulfonylurea or insulin. And also the fasting should be in the morning hours. The fasting should be during night. So the patient receives the meals during morning hours. 2 or 3 main meals during morning hours, during the hours of activity of doing his work. And also we allow liberal fluids, non-sugary fluids during night hours. And please don't mix between intermittent fasting and Ramadan fasting, because it's not the same. This should be very clear. Intermittent fasting is not Ramadan fasting. Professor Amr.
What is GFR to stop sodium glucose transporter 2 inhibitors in elderly? Sodium glucose transporter 2 inhibitors should not be started if the GFR less than 45. Not started if less than 45, but should be stopped if below 30. This is what is recommended. I think there is some studying on use of sodium glucose transporter 2 inhibitors in patients with GFR less than 30, but they will not be effective regarding glycemic control, because they actually act on the kidney. Risk of euglycemic DKA and amputation increase with sodium glucose transporter 2 inhibitor. Euglycemic DKA, it occurs, yes, in patients with misdiagnosed type 1 patients who are type 1, or patients who are type 2, but the pancreas is the pancreatic function markedly affected, and the patient is on insulin, depending mainly on insulin or only in insulin in long-standing diabetes. These patients may be liable to euglycemic DKA, especially if they are fasting, especially if they are ill and they don't eat. They are liable to euglycemic DKA. Amputation, yes, it first mentioned that in some studies found that amputation increased with canagliflozin, but in meta-analysis of the 3 known sodium glucose transporter 2 inhibitors present in Egypt, this complication was found to not be right. Stop sodium glucose transporter 2 if GFR less than 45. Stop if less than 30, but don't start if less than 45. Please raise your voice, type okay. Revise the method for intermittent fasting to avoid being similar to Ramadan fasting. As Dr. Ines mentioned, the fasting hours should be at night, where during the fasting period you can take non-sugary fluid. During the eating period, don't take high calories to avoid fluctuation of blood sugar. Also is not allowed in patients receiving insulin and the patients receiving sulfonylurea. Insulin resistance, elderly patients with hypertension and kidney insufficiency disease and hypercoagulability management. Insulin resistance patient, يعني I think in يعني هو diabetes is actually the main pathophysiology of diabetes, type 2 diabetes, whether in elder population or younger population, is insulin resistance and beta cell dysfunction. So you have an element of insulin resistance. You have to improve this insulin resistance with diet, exercise, treatment like metformin, which improves the insulin resistance. This is an insulin sensitizer. As I mentioned, TZDs are not preferred in old age because risk of osteoporosis, osteoporotic fractures, fluid retention. But if the patient is not at risk of these conditions, no problem. في كمان pathophysiological difference between intermittent fasting and Ramadan fasting in cases of type 1 diabetes, as there is a big debate. يعني all type 1 diabetes دولت very high risk patients who should not fast Ramadan and should not do intermittent fasting at all. Yeah, there is a problem with type 1 diabetes in fasting. Great problem. Patients are liable to complications, and they are very high risk patients. Should not fast. Should not encourage to fast. Can you please, Dr. Ines mentioned the pathophysiologic difference between هو ده السؤال لحضرتك دكتورة إيناس. Can you please, Dr. Ines, mention the pathophysiologic difference between intermittent fasting and Ramadan fasting in cases of type 1 diabetes, as there is a big debate nowadays about this issue? Dr. Ines.
A very difficult question, but I think our association did a good job about type 1 diabetes and fasting Ramadan. Fasting Ramadan in type 1 diabetes is a very high risk condition, except if this type 1 is very well controlled and is using a modern technology to monitor his blood glucose, or using insulin pump together with very good control and hemoglobin A1C less than 7%. If not, then type 1 diabetic is considered very high risk to fast during Ramadan. And if we are not allowing type 1 diabetes to fast during Ramadan, then we are not allowing him to have intermittent fasting. What do you think, Professor Amr, Professor Omar?
I agree with you. Type 1 diabetes is very high risk in Ramadan and should not do intermittent fasting in other times. No, it's not suitable.
I don't approve of this. No, no fasting for type 1.
No fasting Ramadan and no intermittent fasting.
لا ولا حتى في غير رمضان يعني.
If you are not allowing Ramadan fasting, then you will not allow intermittent fasting.
Yes, okay.
دكتور عمرو, I want to ask you something, please. عمرو بيه. هو احنا ما عندناش, we don't have any studies for the use of SGLT2 above 75. يعني حتى أول ما نزلوا الدواء, when they introduced it into the market, they said above 75 we don't have enough publications to use it. Even in the cardiology cases, all of them are 72 to 75. What about 80s, 82, 83, 84? Do you approve of this?
No. I think even I don't like to prescribe sodium glucose transporter inhibitor even in patient in above 65,
above 75.
I don't like to prescribe it except if the patient is already on it and no complication with it. If the patient comes to me and he's on sodium glucose transporter inhibitor,
IMMEs,
as long as no problem.
Write it in big quantities for all patients, regardless of ketoacidosis, regardless of dehydration that happens in all of them, and regardless of the age. This is very strange. It's a very good drug. I'm not attacking it. But
yes. As I told you, if the patient is on it and there is no problem, I leave it. But I don't prefer to write it above 65.
Yes, كده
above 65. There is a study on dapagliflozin. I don't remember exact age, but it's in geriatric population. It didn't increase side effects except for volume depletion. And volume depletion is important for geriatric age due to, lack of regular fluid intake, decreased thirst perception, and also maybe postural hypotension is important in this issue, which is a complication of diabetes.
مرة تانية, I'm saying I'm not attacking. I just like to point out, please don't choose it above 75.
I think the best is metformin and DP4 inhibitors.
Yes.
Canadian guidelines said the best is DPP4 inhibitors together with metformin for sure. Yes. Okay, thank you very much. And let me start with Professor Hussein Al-Fishawi. And Professor Hussein Al-Fishawi is a professor of internal medicine and in Cairo University. And Professor Hussein Al-Fishawi is going to talk about confidence now and for the future with Galvus. And this is the Novartis presentation. Thank you very much, Professor Hussein Al-Fishawi, for joining our symposium today. Please.
I would like to thank my dear Professor Dr. Ines for her kind invitation for me to be with you today. And it's my pleasure to be with my dear professors and colleagues, my dear Professor Dr. Omar Saadani and dear Professor and colleague Dr. Amr El Melegy to be with you today. And I want to thank Novartis company for their kind invitation to be with you today. To build